OldGuyTalks.com is all about being a better man. Join me on this kick-ass journey. Exclusive stuff for members only in the Old Guy Cave. Opt in now. This is Ors, the Old Guy from www.oldguytalks.com, here with his special guest, Dr. Mickey Barber. Dr. Barber is at Better Life Carolinas, which is an age management clinic, and we're going to talk a little bit more about that. Prior to that, she had been, worked as the CEO of Cinegenics at Carolinas, has been active in the anti-aging field, and she is a doctor who believes that successful aging includes maintaining energy, health, and sexual vigor through shared responsibility of the patient and the doctor team. And one of the things I laugh with, as a matter of fact, I was having a cigar with some of my friends the other day, and they were talking about their doctors, and I asked them, I said, do you have an interest in looking like your doctor? Or the real question is your doctor a role model for who you want to be? And if the answer is no, if you're there for health, you should probably leave. If you're there for disease, well, sometimes disease doctors are fine. It can be regardless of that. But the question is, if they're trying to get you healthy, are they someone that you are trying to mimic? Dr. Barber is also, in November of 2012, she was awarded the top honor in her field, presented with the Alan P. Mintz Award for Clinical Excellence in Age Management Medicine. And she practices what she preaches, folks. She definitely practices what she preaches. Now, before we get started with the interview, I have to read my medical disclaimer that Sue, my IP lawyer, said was okay. This is not the way Sue would have written it, but she said this will do the trick. This is information only. Consult with a proper professional before starting any program. Don't be stupid. You are responsible for your own shit. The old guy is a capitalist and not a socialist weasel. He will be promoting stuff and may be compensated. The old guy only promotes stuff he uses. You will have different results. So now we've got that little legal disclaimer all settled and everything else. So let's start off with the concept before we get into the meat of menopause. What is the concept of age management?
Good question. So age management is a little different than anti-aging, in my opinion, because we're not against aging. That's what happens. It's not a disease, it's a process. But age management is more about kind of a holistic way of managing the aging process. So it's really about disease prevention and about helping us to look and feel as young as we can as we move through the aging process. I kind of from the beginning have been, fighting aging all the way, and I want to cling to those youthful feelings, health, energy, vigor, and cognition that, we had in our younger days.
Sure. We all do, and sometimes people do that with varying degrees of success depending on how serious they are, and a little bit of, I think your genes may be a factor a little bit, but you can also do a lot of things to mitigate that. So let's talk about what happens in menopause, and I want to try to go through various levels of it in terms of in the body. Let's talk about metabolism, muscle mass, and weight gain. What occurs there, and what's the way that happens?
Sure. Can I back up a little bit to answer your first question about what is?
Sure. Okay.
So, part of evolution, I guess, is that, we're not supposed to be procreating or making babies after the age of, let's say, 40-ish to 50-ish for women, probably for men too, which is part of why our hormones start to decline. We're fortunate in this day and age to outlive our hormones, which is part of the reason, patients come to me and other doctors that practice what we do, is that, we're living a much longer life and we want to stay active and be healthy. What happens in menopause, and I really want to back up to what is called perimenopause, so PERI, the period before menopause, which for a lot of women and their significant other is way more traumatic than menopause, because it's a fluctuation in our hormones, sort of preparing for our ovaries to shut down. Why would the ovaries shut down? Because we're not going to be making babies anymore, and so those eggs don't need to be spit out anymore. The first hormone that declines during perimenopause is progesterone. Mm-hmm. Meanwhile, until menopause happens, our estrogen remains very stable. So just for everyone's information, menopause is defined as 1 year without a menstrual cycle. And when the estrogen drops from where it had been previously to down, in some cases, 0, and the FSH and the LH, the brain signals to the ovaries, become very high because the brain is sensing there's no estrogen, so it sends out a louder and louder signal. In that period before then, things go a little haywire because now you have a big imbalance between progesterone and estrogen. So, or as I like to think about progesterone being the brake pedal and estrogen being the accelerator. Okay. So imagine you lose the brake pedal. So for a lot of women in that perimenopause period, their accelerator is going full speed ahead. So a lot of women, before they actually stop having periods, have symptoms like insomnia, struggling with sleep, feeling anxious, having a lot of irritability. I call it PMS on steroids, where a lot of women describe feeling like they want to jump out of their skin. And it's actually how I got interested in age management, because I was going through perimenopause, and that was back in the day when no one talked about it. And I really couldn't find anyone to take care of me, nor any relief for that period of time. Everything was kind of focused on that menopausal period. So I wanted to kind of lay the framework down, because I think a lot of women don't realize what's going on before, and certainly a lot of men. The other hormone that changes in that perimenopause is testosterone. Same reason. Why do we need testosterone? We're not supposed to be making babies. We don't need to be having sex. So that starts to decline as well. All of those things in concert start to affect our metabolism. Mm-hmm. So at around 40, our metabolism decreases about 10%. So we know that most women, if they are not proactive, will put on about 10 pounds every decade after 40.
Okay.
Now that's pretty significant. Mm-hmm. The average age of menopause in the United States for women is 52. So that perimenopause can start at 40, 45, 47, and it's a variable amount of time until that estrogen then drops, and the woman does not have a period for a year, and then you are officially in menopause.
Mm-hmm. Okay. And the metabolism changes continue on.
Continue on, right. So that 10% drop is another 10% in the next decade, is another 10% in the next decade. So I tell women, I'm 63, so I can speak to this because I've been through the 40, 50, and now I'm in the 60s, that whatever a woman was doing, eating, their exercise routine at 40 will need to be changed, probably in about 8 to 10 years. And then will need to be changed again, probably in 8 to 10 years more. Things sort of level off in the 70s, but it can be pretty dramatic between the ages of 40 and 70.
Oh, okay. So I did not realize that there was the precipitous decrease in weight over time. So that's a very significant thing.
It is. And accompanying that is a loss in muscle mass. So what happens is the body composition really shifts. And, if you're around women, you may have noticed, or if you listen to women, you may notice their complaint that, oh, I used to have a flat tummy and now, there's kind of a pooch there. Well, that's sort of a natural redistribution as our ovaries and uterus are not carrying babies anymore. That area starts to fill in with fat. And so there is kind of that natural accumulation. Things start to shift around a bit. Mm-hmm. We start to lose muscle mass if we don't do something about it, and bone if we're not proactive. So, that's why you see, some women start to, kind of bend forward, their posture shifts a little bit because there's a real change in their body composition.
So what's the difference here in terms of bone density, and what happens there, and what's the rate of degeneration there?
Say that last question again.
What's the rate of degeneration in bony changes?
It really depends. I would hate to put a number out there because it depends, first of all, on your activity level. The more sedentary, the more rapid you lose bone. It depends on your genetics. A family history of osteoporosis is going to put you at a higher risk. It depends on your hormonal balance. Extended periods of time with low estrogen puts you at an increased risk for bone loss. It depends on your vitamin D level, particularly if you're someone that historically has had a very low vitamin D, that puts you at a greater risk. So it really depends. It's very individual.
Sure. Okay. We talked about the changes in fat composition and loss of mass. What occurs in terms of skin tone and facial tone and all that stuff? So.
It all starts to change if you don't get ahead of it. I mean, for sure. So estrogen helps to support collagen under the skin, and collagen is really that structural framework that supports our skin. And it's supported by holding moisture. And as we lose estrogen, that collagen starts to collapse. So what you see and feel is real, is that the actual texture of your skin can start to change, as well as you can start to see some sagging. Part of that happens too, because with that fat distribution, unfortunately, we'd like to be able to select exactly where we'd like to lose it and gain it, but we do start to lose some of the fat that's important for our facial structure. Mm-hmm. And so that can start to change as well.
Okay. All right. Let's talk about some of the cognitive things. What kind of changes do you see in memory and cognitive function, focus, and those type of things when people have when their hormones aren't optimized?
Yeah. Well, I would say 9 out of 10 women complain of brain fog, which if you've experienced it, you know what that is. If you haven't, you don't. But it's almost like what women describe as the pregnancy brain, which if you've been around pregnant women, you know that they just seem to forget things more easily and seem to not be able to focus as well. The same kind of thing starts to happen even in that perimenopause, where it's harder to focus, it's harder to remember things. Those are the non-pathological changes that can happen. We do cognitive testing as part of our practice, and we hope to never find any real cognitive impairment. But we know that women, certain groups of women, not all, with low estrogen do have some memory impairment that's real, that can be documented. Rather than what is that brain fog, which is, not a disease and it's going to improve, but there certainly is a greater risk of having dementia, cognitive impairment, and even Alzheimer's, partly due to the hormone shift, because our hormones are anti-inflammatory, testosterone, progesterone, and estrogen. And we know that diseases like Alzheimer's disease, Parkinson's disease, neurologic diseases have an inflammatory component to them. So, getting ahead of that inflammation in the aging process for men and women is really important, and is one of the reasons why we think hormone replacement in most cases is indicated.
Okay. All right. Some women complain of fatigue. What's that all about? I mean, I'm always tired, so but what is it? I don't know about you, but I'm always tired. I wake up tired.
Yeah. No, I'm very fortunate because I'm rarely tired, but I do things to make sure that doesn't happen. One of the main things is getting a good night's sleep. Mm-hmm. I mean, it's huge and so important. And as I mentioned earlier, that progesterone is key. And usually the first hormone that I order for women is progesterone to be taken at night. It's sedating. It's that brake pedal. Mm-hmm. So if you're not sleeping well, my question is, do you wake up rested in the morning? Mm-hmm. If the answer to that is no, that's a sleep issue. Even if you are asleep, but you wake up and you're not rested, we need to go back and really look at that. The other thing that happens at rest, which I swear if men went through this, it's like pregnancy, there would be no children around, but are the night sweats that women have where, you can be sleeping, you're sound asleep, and you wake up covered in sweat to the point where your sheets are drenched. Imagine how disruptive that is for a night. Sure. Yeah. And so, the sleep part of it has a lot to do with the fatigue for a lot of women. And, men who don't sleep well, of course, have similar issues. The other issue too is the testosterone in women is really important for general sense of well-being. So kind of motivation, how do you feel about yourself, body composition, and energy as well. I find a lot of women, once we get them on a good dose of testosterone, are much more energetic. They just feel like they're more connected, they're more interested in going to the gym or engaging in activities because that testosterone is important for the energy. The other thing to look at too is the thyroid. And as our estrogen drops, our thyroid becomes less healthy. So postmenopausal women are more prone to be hypothyroid, in other words, a sluggish thyroid. That estrogen and the thyroid hormones work together. So that has part of the metabolism piece as well as part of fatigue. It can also be a reason, the estrogen and the thyroid, why women have an increased risk of heart disease after menopause, because now the liver doesn't work as well in processing cholesterol. So now you've got higher cholesterol, you've got higher inflammation, you're putting on belly fat. So next thing you know, women's risk of heart disease is up there with men after menopause. So all those things start to happen around that same time period.
Wow. Yeah, the disrupted sleep is a big thing. I recently just got a sleep apnea, a dental appliance for that, and I'm stunned at what a difference it's made in my sleep.
Yeah.
It's just incredible.
Yeah, it's and women get sleep apnea and snoring issues too. And we as part of our intake form, we ask quite a few questions about sleep. And, we refer out to different sleep clinics or dentists in the area, again, because the oral appliance may be the answer. I know everyone's kind of nervous about CPAP, but it might not be what you need. And it can be life-changing no matter which of those choices you make. So the sleep's a big deal, in my opinion. And actually, when I was in perimenopause, sleep was, I would have given $1 million to be able to sleep. And it just, it'll wear you down.
Sure.
And when you're not sleeping, you know what you do? In the next day, you grab the wrong kind of food because, you're tired. And so, maybe if I have that cookie or that candy bar or that soda, it'll help to keep me awake. So it becomes a vicious cycle.
Just a little bit of sugar for that quick buzz, and then next thing you know, you're crashing.
Right.
So, so everyone always talks about what happens to sexual desire, perimenopause, menopause. What happens there?
Yeah, good question. For some women, sex gets better. Because, one, not worried about pregnancy. Number two, not worried about the kids coming in and interrupting you, or, worrying about your kids coming home. Once the kids are out of the house, it kind of frees you up a little bit. For some couples, you have more time together if one or both of you have retired. So there can be some good things about it. But there are some things that maybe make the situation not as favorable. One is being tired. I would say at the top of the list, and for men too, if you're tired, particularly for women, the last thing you want to do when you're trying to get sleep is, roll over and have sex. Men can do that better than women, I think.
So Mickey, I don't know if you saw my interview. I don't know if you know who Mickey McGrath is. I interviewed. She's a sex therapist, and she on her TED Talk, she had like 15 million hits on her TED Talk.
Yeah.
You know who it is, and I don't know if you know. She talked about the most common sex position is doggy style, and she says, and it's not what you think. It's not what you think. It's men begging on all fours and the woman rolling over and playing dead.
That's pretty good.
Yeah, so that goes with your tired comment.
That's right. That's exactly right. I do think that is one of the big reasons women, particularly in that perimenopause when they're not sleeping, are not as interested in sex. But the other part can be, sometimes it can really hurt. I mean, dyspareunia, which is painful intercourse, is not uncommon. And there are a couple of reasons for that. The number one reason is estrogen stimulates the cells on the surface of the lining of the uterus to make fluid.
Right.
And that fluid keeps that vagina nice and lubricated so that sex is comfortable. For some women, that lack of lubrication can start even before menopause. And so that layer of the vagina gets thinner and thinner and drier and drier. And some women, it even will tear and become like almost paper thin.
Ouch.
That can hurt.
Yeah, I can imagine that can hurt.
Yeah. And, you know, if you're the woman and you're thinking, I know this is going to hurt, you know, you're going to be a whole less likely to be excited about having sex. So there are things to do about that. I mean, you know, I use vaginal DHEA and hyaluronic acid, which works really well. We have the Genevieve treatment, which is radio frequency, which is a one-time treatment, which kind of stimulates that whole collagen and all that tissue to come back. And I really want women listening to know that you don't have to just deal with that. And a lot of women, I think, don't think about doing anything about it. They say, well, we just use some lubricant and, you know, it works fine. Well, from a preventive point of view, as that layer gets thinner and thinner and thinner, it puts you at risk for tears in the vaginal wall, for bacterial vaginosis, so a bacterial infection of the wall of the vagina, which is extremely difficult to treat and is usually recurring and then is passed partner to partner. The other thing that happens is that support for the bladder starts to collapse, so women can have stress incontinence. They can, you know, pee when they're sneezing or coughing or jumping, or even when they're having intercourse. So a lot of women, you know, are concerned that, you know, they're going to have a urine leak while they're having sex. So same kind of thing that I mentioned before, there are treatments that are non-invasive that we can do for that incontinence. The other thing that happens, which is kind of weird, is that the vagina actually kind of shrinks and gets a little bit shorter. So for a lot of couples, you know, we have to talk about maybe a slightly different position. You know, using pillows to elevate the pelvis. Doggy style may work better. On the side may work better. And so, you know, if you think about it, if a man is having issues with erectile dysfunction and the woman is having her own issues, you got to have a conversation, and you need to be working together on those issues, or otherwise that whole intimacy thing, you know, can kind of fall by the wayside. And then there's the hormonal component. So the libido part of it, which is mainly testosterone, progesterone, estrogen do help, and DHEA. But, you know, all those things kind of have to work really together. And I find 99% of the women that come in here really want to be sexually active. They really want to, even though the men might not think they do. They just have a few issues that are kind of getting in the way and making it less pleasurable.
Sure. So you touched on hormones, and what? Let's talk about the different kinds of hormones, because there's synthetic, there's bioidentical, compounded. Why don't you give us a little rundown about those?
Yep. So we have hormones that we make in our body, which we've been talking about. We have three kinds of estrogen. We have progesterone. We have testosterone, DHEA. We have a whole slew of other ones. Those are kind of what we think of as the sex hormones, the ones I just mentioned. And then we have the synthetic hormones, which if you took the chemical structure, let's say, of testosterone that we make, it has a certain structure. Well, the synthetic hormones that are available through the pharmaceutical companies have an extra little arm. They have an extra little chemical structure coming off the side, partly because they can patent that structure as opposed to patenting the innate hormone that we make. So if you think about it, so hormones work by attaching to a receptor. And if you have the actual hormone, it's a key and lock kind of fit. But once you add on extra structures, then you don't have that exact fit. So you're more likely to have side effects, and you'll have to use a higher dose to achieve the same ends because it's not an exact fit. Mm-hmm. Where bioidentical or human identical or quote unquote natural hormones are from plant sources. They are the exact structure of what we make in our body, and they are most of the time compounded. Now, people think compounding is a new thing, but it's been around since the 1930s. Mm-hmm. Compounding pharmacies were compounding for animals, pain medication, for oncology, for cancer patients, certain vitamins, children's medications were compounded. So it's not a new thing. But to make these bioidentical hormones, these compounders are taking the raw ingredients, which are typically from yam or soy, and then getting that raw material and put them in different forms for us to be able to use topically, orally, vaginally, for our body to be able to absorb. So it's really in the chemical structure is really the difference.
Okay. Can you give us your perspective on the first pass effect in terms of when you take hormones?
Well, there certainly is if you take an oral hormone. So there are certain hormones that we don't take orally, like testosterone, for example, because it has been shown in the past, and this may change if the delivery system changes so that less goes through the liver. It has been shown testosterone to affect liver function. So we don't use testosterone. There is oral estrogen. I don't use it because we know that as it goes through the liver, it does create some metabolites that have a negative effect, one on the liver and two on inflammatory markers. And that would be pretty typical of a lot of medications. Progesterone doesn't have that same problem. It actually is converted to some degree to pregnenolone, which is a sedating hormone, which is why I use it orally. If you use progesterone topically, so it bypasses that first pass effect. It does not have as much of a sedating quality. So there are some positive things of going through the liver for some medications and hormones, and some not so positive. And in fact, that really is the only one that I use orally is obviously thyroid medication and progesterone.
Okay.
All right. Does that answer the question?
I think so. I think so. How long does it take to get someone on the right mixture, right balance of hormones typically? Is that because my assumption is there's a little bit of an art. There's not a little bit. There's the amount of art to doing that.
Yeah, men are so much easier. You guys are simpler, you know.
I know that's that.
I won't argue that. So for a perimenopausal woman, because remember, we have not stopped menstruating, so the hormones are in flux. I call women in that phase a moving target. So for those women, it takes a lot of partnership with their doctor. And in those women, I tell them, look, I'm going to order X number of milligrams or X number of capsules, but I want you to listen to your body and decide what is the right dose for you. Whereas, first of all, in men, it's pretty easy to come up with the dose. And in postmenopausal women, it's a little bit easier because the production of hormones internally has stopped. Mm-hmm. So for postmenopausal women, they may start to notice a change in 2 to 3 weeks. In the perimenopausal women, it may take a little bit longer because, things are in flux and it's that moving target.
Okay. What happens if you do nothing?
If what?
If you don't do any treatment.
Well, you can. That's a good question. A lot of women historically, and I still hear this at dinner parties and places like that, I don't need hormones. I'm not having any hot flashes. I'm not having any night sweats. I'm fine. I'd really like to change that way of thinking because other things are happening. So you can go through menopause and not have any of those symptoms, but your estrogen is still dropping, which means that your risk of heart disease is going up. that your risk of diabetes is going up, that your risk of osteopenia or osteoporosis are going up, that you can start to get some fuzziness, etc. So, I like to talk about, this is really about your health and not about just, treating the symptoms. Because I think a lot of women kind of fall into that category of, well, I'm not having any symptoms, so I don't really need to do anything about it.
Okay. All right. Okay. I think that's it. So, Mickey, I get to this point here where we're kind of done with the main topic of the interview, but I always like that the old guy is about vices and virtues. And so he likes to find out, we found out a lot about your virtues, but I want to hear a little bit about your vices.
I don't have any.
Oh, no. We all have vices. So let me ask you a couple of questions.
Sure.
If you were to compete in an Olympic event, what would it be?
Is there one for perseverance and stubbornness? If there was, that would be it.
Okay. Well,
I would be a sprinter.
You'd be a sprinter. Okay. Why that?
Well, I've had some genetic testing done, and I know that I have those kind of muscle fibers, and I can, if I'm doing intervals, I beat women 20 years younger than I am. I actually kind of entertained last summer. I was thinking maybe I should train for the Senior Olympics in sprinting, but I couldn't find a coach to help me to do that. No question, that would be it.
All right, perfect. What kind of music do you listen to?
I'm kind of a equal opportunity listener. I like, the old stuff. I'm a big Santana fan. I like Eric Clapton.
Sure.
But, I'll listen to the newer music. I'm not a big country fan. I do like Blake Shelton, but, that's for other reasons. I'm a pretty equal opportunity listener.
Okay. And if you are eating something in the closet, what would that be?
Oh, that's easy. I'm a chips and salsa girl all the way. You could parade in front of me cakes, pies, cookies. I wouldn't turn my head. But put some chips and salsa in front of me, and that's trouble.
That's all trouble. Okay. And do you like to drink alcohol?
I do. I'm a tequila drinker.
Oh my! It goes right with the chips and salsa.
Yeah, but I'm not a margarita drinker because that's a little too sweet. So I just like my tequila with some ice and some fresh squeezed lime, and sometimes just a teeny whiff of triple sec on top.
Okay. Any particular tequilas?
I'm a Patron silver drinker. Yep, I keep going back to it. I try other ones, and I end up right back there.
Oh, okay. All right. Well, Mickey, thank you very much for coming on the oldguytalks.com and talking about menopause. I think we covered a lot, and I think there's a lot for people to digest in terms of when they or someone that they love are going through this point in their lives, because it is a significant change, and it's a challenge for a lot of people. It's a big challenge.
Yeah.
And I think that when you look at divorce rates and things like that, I think about a lot of them come at this time in people's lives.
Right. Yeah. We didn't really talk about the emotional impact for women.
Uh-huh.
But
go ahead. I'm sorry.
I think men underestimate that sometimes. Women, when they come in to see me and they're going through menopause, number one, they're trying to figure out what they're going to do with the rest of their life because they're not able to have children anymore. Their children have left the home. And it's kind of a reboot is how we talk about it, kind of get a new direction. And then really watching your body change and having things happen like a hot flash, which is extremely hard to describe. But it's like if you've had the worst fever in your life and you're in a small box and all of a sudden that fever comes out of nowhere, it's suffocating. You can't control it. And, that lack of control for a lot of women is just, debilitating. Mm-hmm. And like we had said earlier, really being able to talk about it and then do things about it is so important. And, the good news is people like you, men, number one, it's great that you're talking about this on your show, because I think most men don't understand what goes on, and they're afraid of it, and they're afraid to even go near the conversation. And a lot of men and women don't know what to do about it. You back? Can't hear you. I can't hear you. Guess we say goodbye.
Opt in and encourage other old guy assholes like you to opt in also.